Thank you for coming here and joining our interview today. The first question is about the left main disease. The result of main comparison tests and pre-combat have already been reported. What is the additional important question in the Excel trial?
Well, thank you. It's great to be here. The outcomes for left main disease, of course, have been improving with PCI over the years. We've gone from balloon angioplasty to bare metal stents and now to drug-eluting stents. And so far, the data we have comparing PCI with drug-eluting stents to CABG is with the first generation drug-eluting stents, with the sirolimus-eluting Cypher stent or the paclitaxel-eluting Taxus stent. And there, the data suggests, especially from the SYNTAX trial, that in patients who have either non-complex or only moderately complex overall coronary disease, in addition to the left main disease, that PCI may be a suitable alternative. Now, when I say may, none of the trials have been adequately powered or have been definitive enough to show that PCI is as good or better than surgery, especially when you think of the endpoints that really matter to the patient, which is death, myocardial infarction, and stroke. Most of the other trials have emphasized repeat revascularization as a very important primary endpoint. And while repeat revascularization, of course, is something that would be nice to avoid, there are many other types of endpoints that are as important of that. And when you ask most patients, they want to certainly live, so survival is very important. They don't want to have a large heart attack, and they don't want to have a stroke. So those should be the real primary endpoint of the trial. So we think now that with better drug-eluting stents and with better techniques, including intravascular ultrasound and fractional flow reserve, and with better pharmacology such as bivalirudin, and all the improvements in PCI, that now for probably 2/3 of patients with left main disease, those with the SYNTAX score that are low, that is less than equal to 22, or intermediate between 22 to 32, we think that PCI is as good or better than surgery. But we have not yet proven that. And so the Excel trial is all about proving that. And in Excel, we're randomizing 2,600 patients, so a very large study. These are patients with significant unprotected left main disease and a SYNTAX score of less than or equal to 32, who are both eligible for both surgery or PCI. And those patients will be randomized 1-to-1 to either PCI with the Xience Prime everolimus-eluting stent or to bypass surgery. And the primary outcome of this trial is the composite endpoint of death, large myocardial infarction, or stroke measured at 3 years. So we think that this trial will be the definitive answer to whether or not PCI should be considered first-line therapy for many patients with unprotected left main disease.
What is the current status of Excel trial now?
Well, so far we have about 85 of the sites enrolling. We're going to have up to 165 sites, so we're about halfway there in initiating the sites. And we've randomized 414 patients. So we're hopeful that about this time next year, we'll have randomized all 2,600, or at least close to that.
So we can get a result 4 to 5 years later?
I'm hoping, 4 to 5 years. Yes. So not tomorrow, but 4 to 5 years.
Next question is about your lecture, pharmacotherapy for ACS patients.
Yes.
Based on the result of ACUITY, Horizon, and Infusion AMI trials, how do you recommend treating high-risk ACS patients?
Yes, well, that's a great question. And we know that patients who are at high risk with ACS, acute coronary syndromes, either non-STEMI or STEMI, most of those patients do best if they, one, are revascularized. And most will be revascularized with stents, mostly drug-eluting stents. So the question is, how can we do that most safely to get the patients through the procedure so they don't have procedural complications? And then how do we treat them long-term so they don't have either stent thrombosis or new plaques rupture and cause new acute coronary syndromes? So it is very important to use potent antiplatelet agents and potent antithrombotic agents, but not too potent. If they are too strong, then the patient's going to have bleeding complications, and major bleeding complications can make the prognosis for the patient even worse. So we have to balance the risk of ischemic complications and suppressing the ischemia to the risk of bleeding complications and not causing bleeding. So with that said, we have multiple studies now that suggest that for the procedural anticoagulant, the direct thrombin inhibitor bivalrudin alone is the optimal way. And that really balances, it suppresses ischemia very well, and it markedly reduces bleeding compared to either high-dose heparin or low-dose heparin with glycoprotein 2b3 inhibitors. And so in the highest risk patients, those with ST segment elevation myocardial infarction, it actually reduces mortality, prolongs survival. And in fact, even in the Horizons trial, it also reduced the rates of reinfarction with follow-up out to 3 years. Now, the other question is about antiplatelet therapy. And in patients with acute coronary syndromes, both non-STEMI and STEMI, who are not at excessive risk for bleeding, we've seen that the newer, more potent ADP antagonists, either prasugrel or ticagrelor, have been able to further reduce ischemic complications, in particular myocardial infarction and stent thrombosis, compared to clopidogrel alone. Now, both those agents increase non-CABG-related TIMI major bleeding, as well as minor bleeding. And so we have to be careful. The agent prasugrel, in the way that it was used in the Triton-TIMI 38 trial, especially in high-risk patients with prior stroke or TIA, patients with small body weight, or the elderly, was not overall beneficial. And as a result, in that trial, there was no overall reduction in mortality. But ticagrelor is a reversible agent, so it's a shorter acting agent. It has a rapid onset and rapid offset. And because of this, actually, in the Plato trial, it was given to a wide variety of patients and actually not only reduced ischemia, but also reduced cardiac and all-cause mortality. So again, using the right kinds of therapies in the right patients will reduce ischemic complications and improve long-term survival. Now, glycoprotein 2b3 inhibitors don't have much of a role anymore. We hardly use them at all. We use them acutely in patients who have received bivalrudin, who have refractory ischemic or thrombotic complications, and that's maybe 5% of the patients. Otherwise, we don't use the 2b3 inhibitors. There is some interest to using intracoronary abciximab in patients with ST segment elevation myocardial infarction, because you can get very high concentrations of the drug, and that can cause platelet disaggregation and perhaps improve microcirculatory function and decrease infarct size. And we just did a study called the INFUSE AMI trial, which was just published a few weeks ago in the Journal of the American Medical Association, and it showed that intracoronary abciximab on top of bivalrudin in high-risk patients with ST segment elevation MI may modestly reduce infarct size, as assessed by cardiac magnetic resonance imaging. So now this would lead to the need for a large outcomes trial to see if that modest reduction in infarct size, is about 3% of the left ventricle, would lead to an improved survival or improved quality of life because of less heart failure, which would warrant the potential for increased bleeding risks and cost by adding back the abciximab. So we don't recommend that routinely yet. Right now for high-risk ACS, we recommend either ticagrelor or prasugrel. Ticagrelor probably being the favored agents in patients who are not at very high risk for bleeding, and bivalrudin as the procedural anticoagulant.
Next question is about the multivessel disease.
Yes.
We want to know your daily practice, how to treat the multivessel disease. Please provide the treatment strategies between the CABGs and PCI for multivessel disease.
Well, thank you. Well, first, like I answered in the last question, I will say that the antiplatelet agents and the antithrombotic agents are also very important for multivessel disease, and pretty much the same as I just described, and that is bivalrudin is the procedural anticoagulant, and then if it's multivessel disease with an acute coronary syndrome, prasugrel or ticagrelor if the patient is not at excessive risk for bleeding, and if it is with not an acute coronary syndrome but just multivessel disease, then we use clopidogrel, and we will preload with clopidogrel before the procedure. And patients, of course, should be on high-dose statins and all the other optimal medical therapies. Now, that being said, when we look at the randomized trials of multivessel disease, either PCI versus surgery, the most recent one, once again, to look at is the SYNTAX trial. So we only have data with first-generation drug-eluting stents. And as we follow from balloon angioplasty to bare metal stents to drug-eluting stents, we see that in general there does not seem to be much of a difference in mortality. There does not seem to be much of a difference in myocardial infarction. Stroke seems to be lower, clearly lower with PCI compared to surgery, but revascularization is higher. And even with first-generation drug-eluting stents, revascularization is higher. Now, in the SYNTAX trial, when we've got follow-up to 4 years, there were statistically significant reductions with CABG compared to the taxus stent in both mortality and in myocardial infarction, although stroke was lower with PCI, and revascularization, again, was lower with surgery. So we don't have evidence yet to suggest that overall PCI is as good as CABG. However, we can tell that in the low SYNTAX score patients, clearly it seems to be as good in those patients, and perhaps even better because of the prevention of stroke. But in patients with moderate and high-risk SYNTAX scores, we need to have more data now with the newer drug-eluting stents and newer, better pharmacotherapy. I do think that that would show that for low to moderate risk SYNTAX score patients, if you use everolimus-eluting stents or the Resolute zotarolimus-eluting stents, the outcomes would be at least as good or better with PCI. But I think for high SYNTAX score patients with complex multivessel disease, the kind that would need 8 or 10 stents, etc., those patients are still better off today being treated with surgery.
Do you think the SYNTAX score should be the primary factor for our decision making in older patients? Because we have many the other scores, like functional SYNTAX score and the other scores. So
right.
In your routine practice, what do you use?
Yes. So the SYNTAX score, there are many scores that predict prognosis after bypass surgery and after PCI. For example, there is the ASEF score, which includes age, creatinine, and ejection fraction. But in general, PCI and CABG will track together with the ASEF score because the prognosis is poorer for elderly patients with both PCI and CABG. Low ejection fraction, both groups do worse, and high creatinines, both groups do worse. The SYNTAX score is kind of unique in that it's an anatomic score, which was really predicated to predict which patients after PCI are not going to do well. The bypass surgery doesn't really matter if the coronary artery disease is complex or not for the most part because it just bypasses everything. Whether it's a long diffuse calcified lesion or a short focal lesion, the bypass graft will bypass it. So the overall outcomes of surgery are fairly independent of the SYNTAX score, where with PCI, the prognosis is worse with a higher SYNTAX score. So it's been the one score so far that really differentiates whether patients will do relatively better with PCI or CABG. Now that being said, I think the functional SYNTAX score is very interesting, and it should do the same, only better. The functional SYNTAX score looks at whether or not each individual lesion is physiologically significant. Of course, the regular SYNTAX score is just an angiographic score based on a diameter stenosis of 50% for the lesions. Some of those lesions are significant and some are not. The functional SYNTAX score offers the potential to further be able to risk stratify patients by predicting which lesions do not need to be treated and therefore which lesions don't need to be in the SYNTAX score. But so far that's more of a concept that needs to be proven. We also have just published the residual SYNTAX score, which looks at what the SYNTAX score is left after the PCI. And it turns out that that is also a powerful predictor of prognosis after PCI. So incomplete revascularization is, again, an important predictor of what the long-term outcome will be. So I think we have to take all of this into account. What is the overall burden of disease, the SYNTAX score? Which of the lesions are really functionally significant, which is the functional SYNTAX score, and then we have to honestly ask ourselves as interventionalists, what is the likelihood we will be able to treat all those lesions? And I think that if we can treat all the functionally significant lesions and get the residual amount of ischemia left behind near zero, that those patients will do excellent compared to surgery or any other therapy.
Thank you for your comprehensive and careful answer today.